Good afternoon, everyone. I'm Dr. John Shrigley, the clinical lead for the Canadian Partnership Against Cancer's National Synoptic Pathology Project. On behalf of the Canadian Partnership Against Cancer and the Canadian Association of Pathologists, I would like to welcome everyone to today's educational session on the new CAP checklist for breast with Dr. Susan Lester. Before I introduce Dr. Lester and we get underway formally, I'd like to take care of a few housekeeping items initially. Today's presentation will be approximately 90 minutes in length and will include 60 minutes of presentation time to be followed by 30 minutes of questions and answers. The session is being recorded and will be made available to all participants via email once the recording becomes available. Both the live presentation and the recorded presentation are eligible for CME credits upon electronic completion and submission of the pre-circulated evaluation form to pathology@partnershipagainstcancer.ca. Please note that everyone's line has been automatically muted for today's presentation, and we request that you hold all your questions until the question and answer portion of today's presentation. Due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you are having difficulties accessing the WebEx portion of this teleconference, please call WebEx support line at 1-866-229-3239. During the question and answer portion of today's presentation, I would ask you to use the chat section of the WebEx to pose your question. For instructions on how to use the WebEx chat window, please refer to the documentation that has been previously distributed. In order to avoid question collisions, I will pose the submitted questions to Dr. Lester on your behalf as long as time permits and in the order that they appear. In the chat window, please include the following information: your institution's name, the name of the individual posing the question, and finally, the question. Thank you. It is now my pleasure to introduce Dr. Susan Lester. Dr. Lester has a PhD degree from the University of Wisconsin in genetics and is a graduate of the Harvard Medical School in Boston, Massachusetts. She is presently the Chief of the Breast Pathology Service at the Brigham and Women's Hospital Department of Pathology in Boston, Massachusetts, and an Assistant Professor of Pathology at Harvard Medical School. Dr. Lester is an author of many academic papers and has also contributed to books such as the Robinson-Cochran Pathological Basis of Disease, where she's written the breast chapter. She is a member of the College of American Pathologists Cancer Committee and the chair of the CAP's Breast Cancer Protocol Review Committee, and as well she's published a number of papers that relate specifically to the protocols, including a protocol related to ductal carcinoma in situ in the January issue of Archives, and also the invasive checklist in the fall of last year in 2009. So without any further ado, ladies and gentlemen, Dr. Susan Lester.
Well, hello everyone, and thank you, Dr. Shrigley, for asking me to give this presentation. This is my first WebEx presentation, so I hope everything goes well and people are patient. If there are any hiccups along the way, I have to say it's always been a real inspiration to the CAP Cancer Committee when Dr. Shrigley gives his presentations on cancer reporting in Canada, because there's certainly been beautiful demonstrations of the power of these checklists once you have control of the data, either for patient care or for research or for quality assurance. It's really revealed what you can do with these checklists. For routine faculty disclosure, I have no financial interest relevant to the content of this presentation today. The objectives are fourfold. So first of all, just a broad overview of what changes were made to the protocols. Two, a lot of questions arise as to what types of specimens you report with the protocols. Number three, to discuss the data elements that generated the most discussion during the development of the checklist, because those are the ones that are most controversial and usually raise the most problems. And then finally, a question-answer period at the end. So when we started out to revise the breast cancer protocols, there was a prior invasive carcinoma protocol, and so that was updated, and some of the things that were changed, one of them was to separate features resulting in a classification as T4D, which included skin and chest wall involvement. Number 2, we included more data elements about DCIS associated with invasive carcinoma. In the prior checklist, it was just whether or not it was present, and we'll get into that later. More specific information about lymph node metastases and how they're evaluated. We also included reporting of ER, PR, and HER2. And then finally, sort of something new on the horizon now is more and more patients with breast cancer being treated with neoadjuvant therapy, and the response in both the breast and the lymph nodes is a very important prognostic factor. And so data elements related to reporting treatment response were also included. We also developed a separate new DCIS checklist because some of many of the data elements associated with invasive carcinoma aren't relevant when only DCIS is present. And it's, for the most part, a subset of the invasive carcinoma checklist with a couple of exceptions. And then finally, the accompanying notes for both of the checklists were greatly expanded, and we added new diagrams to hopefully aid in reporting the elements. So questions have arisen, why are the checklists so lengthy? They're kind of overwhelming when you first look at them. And part of it's because they really need to encompass different types of specimens with a wide variety of carcinomas. So it could range anything from a mastectomy with only invasive carcinoma, where margins and extent of DCIS may not be so relevant to reporting. On the other hand, you could have an excision with extensive DCIS and microinvasion. In such a case, describing the DCIS and the margins would be very important. Secondly, again, we separated out the components of TNN classification because particularly when we get to the AJCC new staging criteria, people wanted to keep these separate so that in the future these can be looked at separately. So, for example, one suggestion for the 7th edition was that T4 should only include inflammatory carcinoma because perhaps skin and chest wall involvement are not that important to put a cancer into that category. And part of the problem with making any changes, we really didn't have a lot of information on the prognostic significance of skin and chest wall involvement. So separating them out was thought to be would be helpful going forward. Thirdly, each required element did have to be supported by data. We did try to keep the number of required data elements to a minimum, even though there are a lot of them. There were others that were excluded because it wasn't felt there was enough data to support them. And then finally, we really wanted each data element to be something that would be used for clinicians for prognosis and to guide patient treatment. And we're just not there just because they could be there. So there had to be some evidence that this data element would be useful for treating patients. Okay, so those are the broad changes that were made. And we'll just briefly go over what types of specimens you would be able to report with the two checklists. So they're designed for reporting the specimen that contains the most advanced cancer. So specifically, specimens that you wouldn't use these checklists to report would be a core needle biopsy or an incisional biopsy, where later on there's going to be a larger excision with more information about the cancer. You also wouldn't report additional margin excision or mastectomies after a prior procedure that excised the main or most advanced cancer. Now, that being said, in some cases these biopsies may include important information, and that could be included in the checklist. So the most common setting would be where ER, PR, HER2 has been performed on a core needle biopsy, and then you could include that in the checklist for the excisional specimen. Or in rare cases in the core needle biopsy, there will be DCIS with microinvasion, but yet on the excision all you see is DCIS. So again, when you're reporting the excisional specimen, it should refer back, when possible, to the core needle biopsy for staging to include that information. So when you're using the checklist for DCIS, that would be an excisional specimen or a mastectomy that contains DCIS, and that would include Paget disease of the nipple when no invasive carcinoma is present. It would not be used for reporting LCIS because at this time most of the data elements are not relevant to classic LCIS. The checklist for reporting invasive carcinoma would include reporting DCIS with microinvasion. So there was some discussion of which checklist DCIS with microinvasion should go in, and it was felt that more of the reporting elements in the invasive carcinoma were relevant when microinvasion is present. So that was put into the invasive checklist. Of course, any excisional specimen or mastectomy containing invasive carcinoma. And then this new category, so if a patient had invasive carcinoma, for example, documented on a core needle biopsy, and then had neoadjuvant therapy, and there's only DCIS remaining, you would still use the invasive checklist to report the residual DCIS. Now, in the setting of someone who undergoes neoadjuvant therapy and there is no residual carcinoma present or a pathologic complete response, it really wouldn't be appropriate to use the checklist at that point because really none of the data elements are relevant to the reporting because there is no residual carcinoma. Okay, thirdly, we're going to discuss the data elements that generated the most discussion. So these are the ones that generated the most emails and differences of opinion. So these are the ones we're going to discuss are extensive DCIS, reporting margins, mitotic counts, lymph nodes. We'll talk about some of the changes in the 7th edition of the AJCC, then reporting ER and PR, and reporting HER2/neu. So extensive DCIS was probably the element that generated the most discussion. And part of it is just what do you mean by extent. So what we mean by extent is the volume of tissue occupied by DCIS, which is usually expressed by the greatest linear dimension of it. So this is a study where they used a computer and did a three-dimensional reconstruction of the breast, obviously something that is beyond what anyone would normally do in evaluating a breast specimen. And the ductal system involved by DCIS is in pink. And so you can see it's an irregularly shaped area, how, depending on how it was excised, you could express this either as a linear extent or somehow the volume of tissue involved by DCIS. So pathologists fell into three main groups when we started discussing reporting extent of DCIS. So one group said, well, you don't use it for T classification, so why do we even need to say anything? Just say DCIS is there. There's a second group who strongly felt that extent was very important and that the greatest linear dimensions should be measured and reported to the closest millimeter. So detailed sampling, and this is a serial sequential sampling or SSS method to map DCIS within specimens is the best or mandatory method to measure extent. Then a third group which felt that because the volume of breast tissue occupied by DCIS varies so widely, it can really be 1 millimeter focus of high-grade DCIS to some women who have DCIS in all 4 quadrants of the breast. And an estimate of extent is useful to clinicians just to know where the extent falls within that broad range. But because of the pattern of growth within the ductal system, the compressibility of breast tissue, and the difficulties of mapping DCIS, an exact size is not possible to determine. And you can estimate, which is an estimate of the extent sufficient and can be accomplished using multiple methods. So I clearly fall into this third group where I think giving some measure is important, but an estimate is sufficient and accuracy is difficult to obtain. And why is it difficult? Well, because it does involve a complex branching ductal system, and usually it's not imaged well, it's not seen grossly, and you can't palpate it. It's been shown that gaps can be present, so even though it looks like the DCIS has ended, there can be an area of a duct that looks normal and then DCIS on the other side. We know DCIS is often removed in multiple specimens and multiple procedures, so there if you have DCIS in more than one specimen, you can't. It's difficult to know how to measure that. And breast tissue is very compressible. So any woman who's had a mammogram, as you can see in this cartoon, breasts can be, change in size and shape with mammography. I'll just show you 2 studies about breast tissue slumping after excision or the pancake phenomenon, or when they're compressed for specimen radiography. So all of these problems really limit your ability to evaluate extent to the nearest millimeter. So this was a study looking at specimen radiography. So just in this first graph, the black bars are the size before the specimen compression and the gray bars after for each specimen. So you can see there was a significant decrease in specimen size after compression. Some of them quite, like this one, quite dramatic. In the second part of the study, the surgeon supervised the compression and minimized it. So if specimen compression is minimized, certainly you can also reduce changing the specimen size. But in most institutions, this is probably not done, and that's a factor that can change the size of a specimen. Secondly, in this study, they just had the surgeon measure the specimen and the pathologist measure the specimen, and they came up with different sizes. So the breast tissue slumped, or they call this the pancake phenomenon, because it is fatty, soft tissue. And so here, something that the surgeon would perceive as a 1 centimeter margin to the pathologist only looked like a 0.25 centimeter margin. So in this case, they had an invasive cancer. So the invasive cancer didn't change in shape because it's firm and has a desmoplastic response, but the DCIS out in the adjacent soft tissue could certainly slump and change in shape. So why do clinicians want to know? Well, again, extent has this very wide range. If you're dealing with very small cases of DCIS or less than 5 millimeters, in some of these cases, the differential diagnosis could include ADH, and that's important for clinicians to consider. In such cases, wide excision should always be possible if the DCIS really only involves that small area. And some people have questioned the value of additional treatment, such as radiation or tamoxifen in such cases. At the other end of the spectrum, very large DCIS, over 5 centimeters, these are the cases where there's a greater likelihood that an area of invasion will be found. And there's also a greater likelihood of the pathologist missing invasion. In some of these cases, particularly a mastectomy with 4 quadrants of DCIS, it can be very difficult, if not impossible, to examine every involved area under the microscope. And in such cases, a sentinel node biopsy may be performed, particularly if the patient's undergoing mastectomy. So it's helpful for the clinicians to know that the DCIS is that extensive. And in many of those cases, it may not be possible to obtain wide margins, and may help in deciding what type of surgery to be performed. So we consider different methods of determining extent, and we'll go over those. If DCIS is only in one block, so here we're on the end of the spectrum, very small cases of DCIS, you can measure it from the block. But in any other case, as soon as the DCIS is in more than one block, this method will greatly underestimate extent and it shouldn't be used. This is the diagram from the DCIS protocol showing these different methods. So here the DCIS is represented by this branching ductal lobular unit with some calcifications in it and a localization wire marking the calcifications, and we're showing extent as some measure of the volume of tissue involved by the DCIS. So if DCIS is just in one block, you can make a measurement. And again, you're not measuring each focus and trying to add them up. We're talking about the entire volume of tissue involved by the DCIS. So that can be used to give an estimate of how the extent of the DCIS. The second method is serial sequential sampling, and this does provide the most information about the distribution of DCIS and its relationship to margins. But it might not be practical to do for every specimen, particularly for specimens when a diagnosis has not been made yet. If you have a core needle biopsy, you know the patient has DCIS, then this could be a reasonable method to consider. And so in such a method, the entire specimen is submitted, and it's submitted in an orderly fashion, and so that you can map out where the DCIS is in the specimen. When we were preparing the protocols, because we wanted some more information about this method and the block method. 2 papers were written and published along with the protocol, giving information about different ways of measuring extent of DCIS. This is a paper published by Frances O'Malley, and she's showing how they do it at their institution, where the entire specimen has been laid out sequentially and then radiographed, and now they have mapped the areas of DCIS marked by X's as well as the areas of calcifications. And so using all this information and the width of each slice of breast tissue, they were able to come up with a measurement of the greatest linear extent of DCIS.
Susan, it's Andrea. My apologies for interrupting. We've just received a little bit of feedback that some people are having a difficult time hearing. Could I just request that you just speak up a little bit more on the phone?
Okay. Sure.
Thank you.
So that was serial sequential sampling. So now we're going on to non-sequential sampling, or the block method. So one of the reasons we wanted these 2 studies performed was to compare these 2 methods of sampling DCIS. So if you take the number of blocks involved by DCIS and multiply approximately by the width of the specimen, or 4 millimeters, it will give you an estimate. But this method is also going to increase with the 3-dimensional distribution, and so it correlates best with linear extent at sizes up to about 2 centimeters, and then the 2 methods tend to diverge. The advantage of this method is it can be used for any specimen sectioned in any way, and so for the purposes of the checklist, if this was going to be a required element, we had to have something that every pathologist could use for every specimen, no matter how it had been sampled. So this is a method that you can use. It does assume that the entire area of DCIS has been sampled, and so if a breast specimen has been undersampled and not all the DCIS has been sampled, then it will not give an accurate measure of extent. So here we have a case where the area of the DCIS has been well sampled and the margins have been sampled, but they may not have been sampled in a mapped out way where you could actually map out which block came from which slice, and maybe not the entire specimen was completely sampled if much of the tissue consisted of fatty tissue. This is a figure from Frances's paper, again comparing the sequential sampling method to the block method. And you can see that there is a good correlation between the 2 specimens up to about 4 centimeters. Now it's important in their paper the extent of DCIS ranged from 3 millimeters to 9 centimeters. And the average extent was 2.7 centimeters. So most cases of DCIS will fall into this area. In fact, there were only 9% of their cases were over 4 centimeters in extent. In this case, you can see the block method tends to give a larger size. And that's because the block method is also sensitive to volume. So the larger the volume, the more blocks that you're going to will have DCIS as compared to the sequential sampling method, which is the greatest linear extent. However, in these cases, for most women, once you have an area of DCIS over 4 centimeters in size, many of those women will have to go to mastectomy. And whether it's 4 centimeters or 10 centimeters may not be as relevant as the clinicians just knowing that the DCIS is very extensive. And in fact, what we don't know is if you're using these 2 methods, which would be the best method in correlating with any outcomes such as local recurrence or lymph node involvement. It's possible that the volume would be more relevant than the greatest linear extent. But the take-home is they had compared, if you multiplied the blocks times 3 millimeters or the blocks times 5 millimeters, and for their data, probably 4 millimeters would give you the most or the best correlation between the 2 methods. And then the final method is to use margins. If you know DCIS is close or involves 2 opposing margins and you know the distance between those margins, that could also be used as another method for reporting extent in these particular cases. So this is what it looks like in the protocol. So you're asked to give an extent in centimeters. If you want to give the other 2 dimensions, which can be done often in the serial sequential sampling method, you can. You can also, it's optional to give the number of blocks with DCIS or the number of blocks examined. So pathologists should use the method they believe gives the best estimate of extent. Again, the block method can be used for any specimen sampled in any way. The extent of DCIS is an optional element in the invasive carcinoma checklist. So in this case, it would have the most relevance for cases with extensive DCIS with microinvasion or extensive DCIS with multiple small foci of invasive carcinoma. Okay, so now we're going to move on to margins. So another controversial and difficult area. So the challenges with reporting margins are many. So one, the significance of invasive carcinoma and DCIS at the margins is different. The number of margins evaluated varies. The definitions of positive, close, and negative margins vary. The definition of the extent of margin involvement varies. We have the issue that some margins are not real margins. So, for example, a deep margin at the chest wall for DCIS is not a true margin because there's no breast cancer there. The anterior margin going out to the skin, or skin flap margins in mastectomies, again, there may or may not be additional breast tissue there. Surgeons use oriented margins to limit the amount of tissue that needs to be removed to obtain good cosmetic results. If you can have the surgeon ink the specimen, that's optimal for orientation. So for here at Brigham and Women's Hospital, the surgeons have 6 inks in the operating room, and they actually ink their own specimens so that they can decide where one margin ends and another margin begins. So that's optimal if you can do that. Finally, the clinical goal varies in different studies and in different clinical situations. So is the goal to remove all the cancer in the breast, or is it to reduce the recurrence rate if you don't give any post-surgical treatment? Is it to reduce the recurrence rate in the presence of post-surgical radiation or tamoxifen? Or are you looking at disease-free survival? Are you looking at overall survival? Are you looking at 5 years or 10 years? And in addition, the definition of an acceptable occurrence rate also varies. And so all of these features make it very difficult to come up with strict guidelines for how to report margins or what to do with a particular margin finding. So for invasive carcinoma, if the carcinoma was palpable, the surgeons can feel the cancer and completely excise it. So in this particular setting, if we see close or focally positive margins, it's usually due to ink leakage into the specimen rather than that the surgeon has cut through the invasive carcinoma. So when you find these close or focally positive margins for invasive carcinoma, they usually don't correlate with residual invasive carcinoma in the breast. And in addition, most breast surgeons use cautery, so there's another rim of 2 to 3 millimeters of cauterized tissue around the biopsy site in the patient that provides an additional margin. So usually for these cases, for cancers presenting as palpable masses, usually close or even positive margins for invasive carcinoma really don't correlate with residual cancer. On the other hand, in the unusual case of a diffusely infiltrative carcinoma that may have been difficult to define by palpation or by imaging, the surgeon may not be able to determine the limits of the carcinoma in the OR. And in such cases, they may cut through the invasive carcinoma, and in these cases, the margins can be widely positive. And in this case, an extensively positive margin often does correlate with residual invasive carcinoma. For margins for DCIS, this is sort of the opposite setting where you rarely can clearly define where DCIS is either by palpation or imaging. And it is useful to determine the likelihood of residual DCIS in the breast. But we also know that radiation therapy and tamoxifen reduce the likelihood of recurrence of DCIS. So some people have argued that as long as the margins aren't positive, that's adequate. But there's no consensus on what the adequate width of the margin would be. Is it just 1 millimeter, 2 millimeters, 3 millimeters? For patients with only DCIS who may not be treated with either radiation therapy or tamoxifen, a minimal 1 centimeter margin width has been suggested. However, this margin may not be adequate for patients with high-grade DCIS. So for all these reasons in discussing with the panel, it was very hard to come up with uniform reporting guidelines. We could agree on what we would call a positive margin. So this would be a perpendicular margin section, and it would be ink on carcinoma cells. So that's what a positive margin was defined as being. If you're using on-phos margins, or this is the orange peel method, and so the margins are put down as a flat face like the orange peel, then anything in that section would be considered a positive margin. However, this method is generally not recommended for breast specimens, as clinicians usually want to know the distance of the cancer from the margin. So for example, in a positive on-phos margin, you don't know whether it's actually at the margin with ink touching the cancer, or depending on the thickness of the slice, it could be 1 or 2 millimeters away. It was also felt that the extent of margin involvement would be important to include. Unfortunately, it's been defined in a different way in each study. Therefore, we couldn't come up with a single optimal method to define extent of margin involvement. The extent of margin involvement has been linked to the likelihood of residual carcinoma in the breast, and it can influence clinical decisions to perform additional surgery. The best we could do was come up with suggestions for 3 categories for both DCIS and for invasive carcinoma, and these were taken from papers in the literature, but again, each paper defined it in slightly a different way. And so these should be considered guidelines as to what other pathologists have used, but not strict definitions that can be followed. And certainly there may be studies in the future that come up with better ways to define these. So for DCIS, we used focal, which was DCIS at the margin, less than 1 millimeter in 1 block, so very minimal involvement. Extensive had been defined as DCIS at the margin in area over 1.5 centimeters or in 5 or more low-power fields and or in 8 or more blocks. And then anything in between those two would be minimal or moderate. For invasive carcinoma, we use slightly different terminology. Unifocal would be one area of invasive carcinoma at the margin less than 4 millimeters. Multifocal would be 2 or more foci of carcinoma at the margin. And extensive would be at the margin over a broad front over 5 millimeters. Unfortunately, among the many revisions of the checklist, in the invasive carcinoma checklist, the same terminology are used for both DCIS and invasive carcinoma. However, you should go back to the definitions in the notes for how to interpret those. So just apply the same definitions for invasive carcinoma using focal, minimal, moderate, and extensive. And again, these are really suggestions to aid in reporting and not absolute definitions, because there is no definitive study that says that this is the best way of how to report extent for margins. Okay, so moving on, we're going to talk about mitotic counts. So the histologic grade of invasive carcinoma, most pathologists now use the Nottingham histologic score. You could agree that all histologic types of invasive carcinoma should be graded. That includes lobular carcinomas, and the majority of histologic types can be of any grade. There are 2 histologic types that should only have 1 grade, and that's tubular carcinomas. All of those should be well differentiated, and medullary carcinomas all should be poorly differentiated. So one very important component of grade is the mitotic count, but a specific mitotic count is only relevant with respect to the size of the high-power field. So the panel debated whether or not to require a specific number of mitoses and a high-power field size, or to only require the score, because just giving a number without the size of the field is not helpful. So we decided that requiring the pathologist to list the size of their high-power field on each report was excessive, and therefore only the final score is required, and giving the actual number of mitoses is optional. So we wanted to help pathologists determine the mitotic score. And so we gave a method to calculate the size of a high-power field using just a ruler and algebra is included. So you don't need stage micrometer or reticule or any special equipment. And as we'll get to, the measurement of very small objects is also very important for the classification of lymph node metastases. So it's helpful for every microscope that you use to determine the size of all fields, and then you can use that as a measuring tool to measure the sizes of metastases or your high-power fields for mitotic counting. So we also included a table to convert the total number of mitoses to score. This is just, I included, it's also in the protocol, but this is just how you would, once you've measured a low-power field, you can calculate the size of the high-power fields. This is the table in the protocol. It was developed by the Royal College of Pathologists. So once you know your field diameter, you can just read off the table the corresponding mitoses to get each score. So note that the mitotic counts necessary for a score can vary almost threefold. So, for example, if you're looking for a score of 2, it can range from 5, if your field size is this size, up to 14. So it is important to know your field size before determining mitotic score. For lymph nodes, so this was a much expanded section of the invasive carcinoma checklist, because previously only required to state that they were present. We agreed that minimal acceptable processing and examination of lymph nodes must be able to detect all macrometastases, or those greater than 2 millimeters in size. So you need to thinly slice each node and submit all slices for microscopic examination. If you're putting multiple slices of multiple nodes in the same cassette, you can ink them different colors, and that allows you to match up the slices and accurately count the number of metastases. And you have to be very careful about taking nodal tissue from grossly negative nodes for research or for techniques which would preclude histologic examination, because this could result in a macrometastasis being missed. So, for example, if a lymph node is bisected and only 1/2 examined, up to 40% of macrometastases can be missed. So this is an example we had from a consult case where they had done immunohistochemistry on the node, and you can see if you bisected it, there's actually a fairly large metastasis in this half, which you don't see in this half of the node. So if you'd taken this one for histologic processing and this one, for example, for RT-PCR, the patient would have ended up with a category of N0 but molecular positive, because this would have come up positive by RT-PCR. And I'm very concerned about this technique, and that it potentially is going to create a group of women who include both false positive results as well as missed macrometastases if it's not done very carefully. Immunohistochemical studies are not required for lymph node processing. And if you do thinly slice and examine each slice very carefully, the only additional metastases that you should find are micrometastases and isolated tumor cells. We included in the notes some more information about classifying lymph node metastases. When there are multiple deposits in the lymph node, you use the largest one for classification. However, judgment is really required when the overall volume of the number of metastases present would bump it up to the next category. So these are difficult cases. I think you have to use your judgment, and these are cases where probably a note to the clinicians would be helpful, saying that classification of that lymph node metastasis was difficult. We also tried to deal with metastases with a lobular pattern. I'm going to talk about this more in a little bit. If you have extranodal invasion, so the metastasis is invaded outside the capsule of the lymph node, you include that in the total size. And then finally, if you have foci of carcinoma and axillary tissue without nodal tissue next to it, that is probably a completely replaced lymph node, and those are counted as lymph node metastases. So just to go over the AJCC 7th edition, the summary of changes, they're actually pretty minor as far as pathologists. For staging, there was one major change in that if a patient has a T1 cancer and only has a micrometastasis, they were changed to stage 1B. This is a new stage that was created instead of stage 2. So studies have shown that the prognosis of patients with these T1 carcinomas and only micrometastases is more similar to node-negative women than node-positive women. So therefore, they created a new stage 1 group, which now puts them with the node-negative women as opposed to the stage 2 women with positive lymph nodes. But that won't change the T or N classification. It just changes how they're staged. There were no changes made in the T classification. And then the one major change in the N classification was to put an upper limit of 200 cells for isolated tumor cells. And this was done to prevent metastases with a lobular pattern with numerous single cells not forming a cohesive cluster from being underclassified as being N0 with isolated tumor cells. So this is particularly the kind of case that we were concerned about. It's where you literally have thousands or even tens of thousands of tumor cells in a lymph node, but because they're in the lobular pattern, they could technically be classified as isolated tumor cells if you're only counting the largest cluster. So there was some question what number to pick. No, this isn't based on data. This is based more on picking out something that was practical for pathologists to use. So 200 was chosen because it's a number that you can count in a short period of time. Obviously, if you pick 500 or 1,000, it'd be extremely difficult for someone to sit down and actually start counting that number of cells. And it's the vast majority of lymph nodes with isolated tumor cells are well under 200 cells. So this seemed like a reasonable cutoff point to use in terms of the practical nature that pathologists could use. I think an important thing in the AJ 7th edition is the statement that the pathologist should use judgment regarding whether it's likely that the cluster of cells represents a true micrometastasis or is simply a small group of isolated tumor cells. And I think that's key. And a lot of these metastases are difficult to classify, and you really do need to use your judgment. And when it is difficult, reflect that in a note, with the communication. Share the uncertainty with the clinician and say, yes, this is difficult to classify because of the following reasons. For metastases, the M classification changed. This is not just for breast cancer, but for everything. So the PMX category was eliminated. This designation did not add information and did cause confusion when there was a clinical metastasis present, or a CM1, because in general, the rule is that the pathologic classification is more important than the clinical classification, but this was the exception. So a clinical M1 is more important than a pathologic MX, so they just decided to eliminate it since it wasn't helpful. There's no PM0 category except at autopsy, and therefore you shouldn't use this classification for clinical cases. So the clinicians assign a clinical M0 category based on imaging and serologic studies. They also created a new category of CM0 isolated tumor cells to classify patients with disseminated tumor cells detected only by special techniques because of the uncertain clinical significance of these findings. So they needed to have a special classification somewhere between M0 and M1, and so this category was created. Okay, so now we get into reporting estrogen and progesterone receptors. So guidelines from ASCO and CAP for reporting ERPR are actually impressed at this very moment at the Journal of Clinical Oncology, and we'll have to revise the checklist after the official guidelines have been released. But there were a lot of controversies in reporting at this conference, and because in many cases the data is limited or is not obtainable, these controversies are going to continue to exist into the future. So one of the big controversies was the lower limit of clinically significant positivity, in which we really don't know what it is. And definitions of negative have varied from 0% to less than 1%, even up to 20%. So the ASCO CAP panel could agree certainly anything higher than 1% should be considered some category of positive. But they did agree that less than 1% would be considered negative. But note that this is different from the all-red score, in which if you had less than 1% positive cells, but you had moderate to strong intensity of staining, it would be considered a positive result of a score of 3 or 4. So again, when we started discussing quantification of estrogen and progesterone receptors, there were 3 main groups of pathologists. So one group said that you only need 2 categories, because if the results of the test is used to treat or not treat patients with hormonal therapy, then you only need 2 categories of negative and positive results. There's a second group that thought more categories should be reported. And we do know that carcinomas do vary in the amount of hormone receptor present, and this information might be helpful. So this group wanted to report both the percent positive cells and the intensity of positivity, and this can be used to generate an H-score, which gives you 300 different categories of positivity. And then there was a third group who thought that probably 3 to 4 categories were optimal, because even though we do know that carcinomas vary in the amount of receptor present, much of the variation currently seen in immunoreactivity is due to differences in antibody type, antigen retrieval, fixation, time to fixation, and numerous other factors. And therefore, the ability to quantify the amount of receptors is limited and can probably only accurately identify 3 to 4 groups. And this is supported by some data, such as this from Stuart Schmidt and Laura Collins, where they looked at 825 cases of invasive carcinoma using immunohistochemistry. As you can see, 27% of their cases were completely negative, 59% they called 100% of the cells positive, and only 14% of the cases had intermediate levels of ER positivity. And even in here, the question is, certainly some of these are cancers that have lower levels of receptor, but in other cases, possibly it's due to fixation or overfixation or underfixation or some technical issue. The question is really, can you use this information to either decide should a patient also get chemotherapy in addition to hormonal therapy? Should they be given an aromatase inhibitor instead of tamoxifen? And those are all questions that are unanswered. So in the current carcinoma checklist, we struggled with even reluctance on the part of some pathologists even to call a result positive or negative. So what's currently there now is you just you report if there's greater or equal to 1% of cells present, and then people did feel like there should be some percent given. Because of this category of less than 1%, it's hard to fit into clearly positive or clearly negative. That ended up being a separate category. And then if it's really 0%, there's a category for that. However, once the ASCO CAP guidelines come out, it will be revised. So the first part is very similar, in which you would report a percent positive cells, a separate category for less than 1% or 0%. But then it was also felt that the average intensity of tumor cell staining should be provided as well. And then they're also recommending that an interpretation be given as positive, anything greater than 1%, negative, if less than 1%, or if it was uninterpretable. And then this information could be used to either give an H-score or an all-red score. The recommendations will also probably include always reporting internal controls, and this is actually very important because most false negative results, the normal cells will not be immunoreactive. So it's always very helpful to document that the normal cells are immunoreactive, or if they're not, question the validity of the assay. There should also be appropriate external controls, and of course, we should all be looking at our standard assay conditions. Reporting ER/PR for DCIS was also very controversial because using ER to guide therapy for DCIS is only supported by the results of one study that's still only published in abstract form, although by report the published results will be published in the future. In this particular study, the patients who had ER-positive DCIS did have a lower rate of local recurrence when treated with tamoxifen. There were fewer patients with ER-negative DCIS, and the study had too few events to determine whether or not there was a benefit. So some people still question the value of even performing ER on DCIS or using it to make treatment decisions. It is true that the ER status of DCIS is currently being used to exclude patients with ER-negative DCIS from clinical trials designed for ER-positive DCIS. So clinicians may or may not choose to use ER status of DCIS when deciding on treatment options, and so we left reporting of ER for DCIS as optional, and there's really absent data for the use of PR for DCIS. And in this case, any number of positive cells was considered a positive result. So this is the current optional reporting element for ER or PR in DCIS, and just saying whether or not immunoreactive cells are present or not present. Yeah, it's more difficult than invasive carcinoma because sometimes normal cells appear to be intermingled with the DCIS, so it's a little difficult in some cases to determine whether it's positive or not. Reporting the results of HER2/neu for invasive carcinoma, previous guidelines had already been issued by ASCO and CAP for HER2, and we follow those guidelines either for using immunohistochemistry or for FISH. So for the immunohistochemical studies, you just report as the score 0, 1+, 2+, 3+, using the definitions as in those guidelines. The same thing for FISH studies. Also report whether that's not amplified, equivocal, or amplified. And again, I think it's very important now to give the average number of HER2 gene copies per cell and the average number of chromosome 17s per cell, because it's still not yet clear whether the ratio is more important or whether the absolute gene copy is more important, and that's still being investigated. And so having both pieces of information can be very helpful instead of just reporting the ratio. So in conclusion, the CAP checklist provides a format for reporting all generally accepted and data-supported elements for breast cancer reporting. And it facilitates the collection and analysis of all these data elements. And although the checklist was developed by a panel of 14 physicians and underwent multiple reviews and revisions by numerous other physicians, there are certainly many areas where it could be improved, and we do welcome suggestions. And as I said, it's going to need to be revised with the new ASCO CAP guidelines for ER/PR, so this is a good opportunity to make changes in it. And I'm sure we'll have additional studies in the future that will provide more specific means of reporting or even better ways to report the data elements. So with that, we're to our last component of the session is to answer additional questions about breast cancer reporting. So I look forward to your questions.
Thank you, Susan, for that very clear and very helpful presentation. We already have a number of questions that have come in, and I'm sure people are going to type in other ones as we're going. So the first question we have is from Dr. Judith Hugh, University of Alberta, and the question is as follows. Is format brackets explicit use of the CAP protocol, close brackets, necessary so long as each data element is captured?
Well, thank you for Dr. Hugh for, I think this is, so it sort of gets to the synoptic reporting elements and in how you're using the checklist. So I think for patient care, doesn't matter how it is reported as long as it's clear to the clinicians how you're reporting. So certainly there are more concise and succinct ways to report the elements. If the elements can be captured as separate data points so that you can analyze the data, that's very helpful. So if that can be done in a different way of reporting, that would be helpful. The other, I guess, component of how you report it is, at least in the United States, is fulfilling requirements for passing inspection, or what is required by the College of American Pathologists for passing inspection. So there's a lot of debate right now on whether or not synoptic reporting is going to be required, and whether or not it is, and how you define synoptic reporting. So I think that is really going to depend on where you are in your institution, and and how these guidelines are developed. But I would say the most important thing for patient care, no, it doesn't matter how you report them.
Okay, another question from Dr. Judith Hugh, University of Alberta. Do you have any advice for incorporating additional, i.e. requested by local oncologists, data elements such as fixation times, extranodal extension, etc.?
Like how you would incorporate that into the report?
Yes.
Well, I think one thing, on the one hand, it's really helpful to report as many elements as you can in a standard format, because it really allows you to compare cancers across institutions, across countries, or even there's this dream of having a global database to be able to collect this data and analyze it worldwide. But on the other hand, we all know that every pathology specimen is slightly different, and so you can't squeeze every specimen into one of these checklists. And so there's always going to be elements that stand out, and I think we should celebrate those and think of those as that's a good thing. Like, so if you have to write a descriptive note or a comment or something about it that falls out of the checklist, that's a good thing, because that's recognizing the diversity of the pathologic process. So if it's something, so I guess there's that element, sort of the unique cancer, the breast cancer that looks like small cell cancer, the metaplastic cancer that is bone in it, something that's really unique and different, that falls out of the regular checklist elements. That just would have to be dealt with in a descriptive comment in text. If it's some element that your clinicians would want on every single case, I guess you could just build that in. You could build in your own institution-specific checklist and just put that on your checklist and collect that as your own data.
And a third question from Dr. Hugh. Do you have any recommendations regarding the use of immunohistochemistry for sentinel lymph nodes in patients with invasive lobular carcinoma due to the redefinition of micrometastasis? And if IHC is recommended for sentinel lymph node biopsy, should it be done in cases without sentinel lymph node biopsies as well?
So we haven't recommended immunohistochemistry as a routine method for lymph nodes in any setting. That being said, pathologists have to use their judgment. I think if you know it's an invasive lobular carcinoma and you have any suspicion that there might be involvement of the lymph nodes, I certainly personally have a very low threshold for ordering immunohistochemistry. In those cases, it's not because I'm looking for isolated tumor cells, but because I'm concerned that because the cells can closely resemble lymphocytes, that I may be missing a much larger or more extensive metastasis. So I guess as far as the protocols are concerned, immunohistochemistry isn't specifically recommended either for sentinel nodes or non-sentinel lymph nodes, and pathologists should use their judgment in using immunohistochemistry for evaluating nodes where there's a histologic finding in which you're suspicious for invasive or suspicious for metastatic carcinoma, but you can't make a definitive decision based on H&E alone.
Okay, we have a question from Dr. Raymond Mong in British Columbia. Has the T changed based on skin involvement?
No, the T categories stayed the same. So the only change we made in the checklist was just to be specific about it. In the old checklist, all you did was check, was it T4A, T4B, T4C, T4D. So it didn't really specify, beyond that what type of skin or chest wall involvement was present. So all we did was to split those out as separate data elements, and so you could follow those separately if you were collecting that data. But the actual T classifications have not changed.
Okay, another question this question is from Laval University, Quebec City, from Dr. Popa. In a case of lobular carcinoma metastatic to lymph node, what is the difference between micro and macro metastasis?
So some lobular carcinomas you can actually measure. So if you could measure a greater than 2 millimeter cohesive focus of invasive carcinoma, that would be a macrometastasis. So it can be difficult distinguishing a micrometastasis from a macrometastasis when you have this very diffuse pattern of involvement of the lymph node. So I think in that case, the 200 cells clearly gets you up to micrometastases. So it's not N0 anymore. Beyond that, that's when you really have to use your judgment. So if I was dealing with a lymph node that literally had tens of thousands of cells, whereas if you, in your mind, push them all into one area of the lymph node, it would be over 2 millimeters, I would classify that as a macrometastasis, but I would also include a note saying that this node was difficult to classify because of this diffuse pattern of involvement that's given the number of cells present, favor classification as a macrometastasis.
Okay, we have a question from British Columbia, from Rock Robertson and Cranbrook. You showed an IHC stain to assess ITCs. Do you do IHC on all negative nodes?
No, what we do is we only do H&E on our lymph nodes, so we only use immunohistochemistry when we see something by H&E that we find difficult to classify. So specifically, in a case of lobular carcinoma where it's a low-grade, well-differentiated lobular carcinoma, it can be easy to miss the cancer in the lymph nodes. I know this is very controversial, and most institutions do use immunohistochemistry. I guess in reviewing the literature, the value of finding smaller lymph node metastases is still questionable. So that was why we did not come out with a recommendation that immunohistochemistry should be performed. Now, it is extremely important to find all the macrometastases, so we could all agree on that. I'm particularly concerned about the use of the new RT-PCR method to look for smaller lymph node metastases, because in that method, there are already published papers where pathologists have split lymph nodes in half and used half for RT-PCR and half for immunohistochemistry, or half for routine pathology, and then they come up with even 25% of their patients fall into this N0 molecular positive category. And that's a huge concern because some of those patients really have macrometastases, and some of them have false positives, and some of them have micrometastases, and some of them have isolated tumor cells, and you can't really tell them apart. So I guess just once you have found all the macrometastases, the value of finding these smaller metastases is still unclear.
Okay, we have a question from Dr. Raymond Mong in British Columbia once again. Please comment on fixation for ER, PR, and HER2.
Yeah, so this has been discussed in detail, and certainly underfixation is a problem, and so I believe what they're going to come out with is that 8 hours is a minimum amount of fixation. But please do check the guidelines when it comes out because it's gone through multiple revisions. But I believe this is what it's going to say. So 8 hours is a minimum amount of fixation. The issue of overfixation has been very controversial because the HER2 guidelines came out saying 48 hours, but really based on no data at all. In fact, the data suggests that it's only after many days or even weeks that there's change in immunoreactivity. So I believe the new guidelines are going to go to 72 hours. Again, not really based on specific data, but it was thought that if you increased it to 3 days, and that would take care of weekends, which was an issue before with the previous guidelines. So presumably if up to 72 hours of fixation is allowed, then 99% of pathology specimens will fall into that category. But I agree, that's been a very difficult area, and I think it kind of violates what we would like to see, which is first you identify a problem and then create guidelines to avoid that problem. In this case, I think the guidelines came out before the data was there, and that the data hasn't really shown that fixation, for even 4 or 5 days affects immunoreactivity.
Hello?
Hello, I'm here.
Oh, sorry, Susan, we got cut off there. Sorry about that. We'll continue with the questions now. There was a question from Dr. Mark Reichenberg in Orillia, Ontario. Please comment on how you would handle a situation where you suspect ink on tumor could be the result of artifactual seepage of ink during gross dissection of the specimen. Do you look for the presence of electrocautery artifact at the tumor edge covered with ink?
Yeah, this is always a problem, and not only is there a problem with ink or not ink, but even the color of ink. We call these our rainbow margins, where you end up with multiple colors of ink. So one thing that can be helpful is when there is a specimen radiograph, to use the specimen radiograph to help see where you're taking the margins and how close they are to the cancer. And so what I like to do on the specimen radiograph is just write on the specimen radiograph those 4 margins. Now, obviously, you're missing the other 2 margins unless you do a 90-degree specimen radiograph. But at least you have those 4, and then as you're taking the margins, specify, this is medial, this is lateral. And one of the really helpful things that we did early on was, because up to a certain point, then you could use yellow could be any margin. Every person inking their specimen just decided what colors. And so several years ago, we just mandated, so black is always deep, and blue is always interior, and yellow is always. So every margin has its own color. So that was helpful in just making it simpler, when you're looking at a specimen, to know what color corresponded to what specimen. So I think correlating with the specimen radiograph can be helpful in identifying which margins are close, and particularly when you get some ink smearing and mixing together. I agree, there is cautery on the specimen edge. That's helpful because at least you know that the surgeon was that close enough that you did get cautery artifact. Now, sometimes there are problems because the surgeon will cut in and then back off. And so we've had surgeons sew specimens back together again, but you actually have cautery on the cancer, so you have to be careful of that. You also have to be a little careful that some surgeons don't use cautery, so particularly in mastectomies, so that's a real controversial area of what you do about the skin flap margins or the superficial margins in mastectomies, because not all surgeons use cautery to develop those skin flaps. So there, whether or not cautery is present or not, may or may not be helpful in determining whether the tumor is actually at the margin. So I agree, that's a really difficult area. Sometimes cautery can be helpful.
Okay, the next question is from Dr. Karen Scallis, I think the pronunciation is. how can we minimize the shape change, brackets, pancake effect, close brackets, during fixation? Are there any suggestions?
Well, the one thing, the one study says, if you are doing specimen radiography, minimizing it can be helpful. I think having the surgeon ink the margins is helpful, because then the surgeon is inking the margins as he or she sees them in the OR, and clearly once the specimen changes shape, then our perception of where margins are can also change. I don't see how we can really, I mean, maybe someone out there has a better idea. I mean, once it's kind of slumped, I don't really see a way of trying to reconstruct how big a specimen was when it came out of the OR. I mean, this is sort of that's kind of similar in measuring margins on rectal carcinomas, because there it's very, the margin is very critical, and we know that colonic segments contract, and so there the suggestion is, to take a good gross measurement as soon as the specimen comes out of the OR, and not wait, and certainly not measure it after fixation. But that's probably not practical for breast specimens, and a lot of times because we're only really measuring these margins after the specimen's been fixed and processed, and we're looking at it under the microscope. So I think we just have to accept that there is slumping and there is change in the shape of the specimen, and when we report a margin as 3 millimeters, that's 3 millimeters plus or minus probably quite a few millimeters. And that's probably as accurate as we can really be.
Okay, we have a question from Dr. Bill Chapman in Toronto. If the tumor cells are negative for ER/PR, then do you recommend submitting another block for testing? Also, in your practice, do you submit the area with the most differentiation or areas with the least differentiation?
Okay, so for the first, if the cancer cells are ER/PR negative, that's where it's very helpful to have normal adjacent tissue. So if the normal adjacent tissue is positive and the cancer is negative, I would feel confident that the assay is working, and I wouldn't repeat it. The only exception to that would be if the cancer looked very well differentiated to me, and that would be an unusual result, although I can't say I've seen a case where part of the slide was positive and the other part of the slide was negative. So in a theoretical sense, if something looked well differentiated and the normal was positive, I probably would still repeat it. And it points out the importance of having, or when you're selecting a tissue for ER and PR, make sure that when possible that there's normal tissue on the same slide. If the normal tissue was negative, then I would certainly repeat it, because that would suggest that there's either something wrong with the antigenicity of the tissue or something wrong with the assay. Another issue comes up is where a cancer was negative for ER/PR on a core needle biopsy and then goes to excision and you have more tissue. So here our policy is to repeat it on the excisional tissue, because often in the core needle biopsy you may not have normal tissue, or you may have very limited sampling of the invasive carcinoma. And so, you just feel every patient deserves a second chance to figure out whether or not they would benefit from hormonal treatment. So we would repeat negative cases on cores on the excision to try and, again, we're trying to find something that's positive. So if it was positive on the core, there's no point in repeating it on the excisional specimen. We also repeat ER/PR and HER2 on after neoadjuvant therapy. So in that case, in most instances, we're looking for another treatable target. So if the cancer was negative for ER/PR HER2 prior to treatment, we're looking for something positive after treatment. So in most cases, we don't think that the treatment's actually changing the expression, but either it could be a sampling issue, because again, before treatment, we're often only looking at a small part of a very large cancer that's undergoing neoadjuvant therapy. It can be selections. We've had cases where patients had both ER negative and ER positive cancers prior to treatment, and then, but the treatment, the ER negative cancer selectively responded to it. So after treatment, their predominant cancer was ER positive. With HER2, we've seen fewer changes pre and post treatment, but we have seen changes both ways, either positive before treatment and negative after treatment, or negative before treatment and positive after treatment. If you have a positive marker before treatment that then becomes negative after treatment, usually the clinicians here don't use that to change treatment because we don't know if that was a temporary change. We don't know if that would be reflected in metastatic disease. So something going from positive to negative is generally not used to change treatment. On the other hand, if the result was negative before but then becomes positive after, that does mean that the patient is another treatable target, and they do use that to either also include hormonal therapy or HER2-directed treatment. So I think I got back to the original question about whether or not to repeat them. It's really complicated, and that's why there's a huge panel and a lot of discussion about reporting and how to report. And when the guidelines come out, I think it's probably going to be a 30 or 40-page article, very detailed in all the issues of reporting ER and PR.
Okay, we have a question from Sunnybrook Health Science Center in Toronto. What synoptic report do you use for encysted papillary carcinoma, in situ or invasive?
Well, we had a whole separate discussion of these, or even how to classify them. And so, fortunately, these are extremely rare. And I would probably personally say that this probably falls outside the checklist because it doesn't really, so what we're talking about is carcinoma, completely circumscribed, but with no myoepithelial cells. So the best studies say that these act like DCIS. They have a very good prognosis, particularly if the entire carcinoma is encapsulated and there's no surrounding DCIS. They have extremely favorable prognosis. But on the other hand, they have no myoepithelial cells, so by definition, you could say they were invasive cancer. So we did have a discussion about, even how would you give them a T classification. And I have to say, to be honest, because I find it difficult either to call them TIS in situ or, if you gave them a T classification based on size, so often they can be 1 or 2 centimeters, it would come out, like a T1C or something, which would make it sound quite ominous. And so I think if we were to use the checklist, I would report it as in situ carcinoma, although I know a lot of people would probably be uncomfortable doing that. And so, although when I sign out these cases personally, what we do is top line it, encysted papillary carcinoma, we give the size, we describe it, and then in the note we say, the clinical outcome of these cases is reported to be very similar to carcinoma in situ, and then suggest classifying them as TIS. I think what we decided is that you would either classify it as TIS with a big note, or some people didn't want to classify it at all, but just leave the differential diagnosis in the note saying, it's either an invasive carcinoma with a very good prognosis or it's an in situ carcinoma. I think what we did agree on is that you shouldn't just classify it as T1 whatever and then not put a note in. But I agree, it's a really difficult area of carcinomas, and they don't really, it would be difficult to report them using the checklist.
Okay, there's another question from Mark Reichenberg in Aurelia. Do you provide intraoperative frozen sections of sentinel lymph nodes given that tumor tissue, i.e. micromets or ITCs, can be lost while trimming the frozen tissue?
Well, we do. Obviously, it should only be done when the surgeon's willing to proceed to do a full axillary dissection. If there's nothing, the surgeon's not going to do anything based on that information, then no, you shouldn't be freezing them. We do freeze them. We freeze the entire node. So the biggest problem that we had early on in false negatives was when, the node was cut in half and only half was frozen. As I showed, when you're dealing with small, and small meaning, 4, 5, 6, 7 millimeter lymph node metastases, when you cut a node in half, because they, the carcinoma is coming in from the lymphatic, so it's not evenly distributed in the node. It's at one pole of the node. In fact, Monica Morrow recently had a nice paper showing that if you have, you can see the blue dye, so if you can actually capture the node at the moment when, part of the node is blue and part of the node is not blue, then the cancer's in the blue side, where the lymphatic's coming in. And so that's why when you cut them in half, because the cancer is coming in on one half of the node, that you often miss lymph node metastasis. So that was one thing. If you're going to freeze the lymph nodes, then freeze both halves. The objective, again, is to find the macrometastases. And no matter what you do, I think no one out there is using any kind of method that's going to find every micrometastasis and every isolated tumor cell. Don Weaver has published some nice papers talking about, how many thousands of slides and how many, hundreds of thousands of dollars you'd have to spend to find every isolated tumor cell in every lymph node. So those are really beyond any existing technique that we have today. So the objective of frozen sections is to find the macrometastases, which you can do reliably by frozen section. And then the surgeons understand that once we embed the tissue and do more sections, we may find a micrometastasis or isolated tumor cells on further sectioning.
Okay, we have a question from Dr. Dimo Devaris, Kitchener-Waterloo, Ontario. How do you handle multiple cancers in a single specimen in checklist? And is margin status dependent on closest tumor, even if it's not the tumor used for PT categorization?
Yes, this gets really difficult because there is a subset of invasive carcinomas where there are multiple carcinomas present, and we did put in a long note with a list of, so one thing to consider when you're seeing multiple cancers is why does the patient have multiple cancers, and that is helpful in determining, what's the biology of what's going on, and what do you do with some of these other factors that you're reporting. So the most common category is the patient with extensive DCIS that's given rise to multiple cancers. So these cancers are all cousins of each other, so they're not necessarily identical. In fact, I've had a case where the DCIS was very heterogeneous for ER/PR/HER2. So you had everything from triple-negative DCIS to triple-positive DCIS to ER/PR-negative HER2-positive DCIS, and had given rise to multiple cancers, again, with every possible combination. And so it can be really complicated. That being said, in the vast majority of cases, the DCIS has one pattern of ER/PR/HER2, and all the invasive cancers coming out of it have the same pattern, and they're all very histologically similar in appearance. And that's the kind of case where it's helpful for the clinicians to know the extent of the DCIS, to know the biology that's going on there, because if you can do an excision wide enough, you should be able to get around the invasive cancer, and you should be able to get around the area of DCIS. The second most common category is you have an invasive cancer that has extensive lymphovascular invasion, and so it's really giving rise to intramammary metastases. So in that case, the other cancers are really metastases from the primary cancer, so they look the same, they have the same pattern. So there, again, there's really no point in doing additional studies on the smaller foci of cancer because it's really the same cancer, and again, it's helpful for the clinicians to know what's going on, because that's something that's not surgically treatable. You're not going to be able to get around every lymph node metastasis in that type of cancer. And then the third main category is where you really have biologically separate cancers that can look different, that can have different patterns. A subset of these patients will be patients with germline mutations, and so in that case, the cancers may look similar, like a patient with a BRCA1 germline mutation may have multiple cancers that are also similar in appearance. but they may be in different parts of the breast. They are often not associated with DCIS, often not associated with extensive LVI. So whenever you have multiple cancers, it's helpful to think, well, why am I seeing the multiple cancers? What's the biology behind them? And so we put in a whole section to try and be helpful with that, because that really hasn't been discussed or widely in the literature. What do you do with those cases? In terms of reporting them, yes, the checklists become very complicated, because the checklist should be directed towards the largest focus of invasive cancer. So the data elements that you're reporting, for the most part, in histologic type and grade and size, would refer to that largest cancer. But on the other hand, some of the other elements, like the lymph node status or the margins, are going to refer to all the cancer that's present. So that's where it gets a little complicated. Also, in rare cases, you would have a large cancer that's maybe well or moderately differentiated, but then you have a smaller cancer that may be poorly differentiated or of a different histologic type. So there, it's appropriate to do the ER/PR/HER2 on, well, I would do them on all the, in that case, on both cancers. If I thought they were really histologically different, I would do the studies on both and report them. So this is the kind of case that's going to take a note at the bottom to say that these additional studies are being reported on the smaller carcinoma. And again, with the margins, so clearly the final margins that you're reporting are going to be relevant to all the cancers. But if the margin positivity is for one of the smaller cancers, it's helpful to also explain that in the note. So a typical case would be the patient has a 3-centimeter palpable cancer, and the clinician, the surgeon could feel it, knew they got around, it was completely excised, and then you report that there's, the margin is positive for invasive cancer, and the surgeon's going to be mystified because, you're going to say, well, that's clearly not true because I could feel it and I'm around it, and that must have been ink leaking. But in fact, what the pathologist is seeing is that associated with that big palpable cancer, there are multiple smaller foci of invasion around it, probably due to, maybe because there's a lot of DCIS and there's, more foci of invasion. So there, it's very helpful in the note to say, that yes, invasive carcinoma is at the margin. It's not, it's not the 3-centimeter cancer, but it's actually, a smaller focus of invasive cancer. But I certainly agree. Whenever there's multiple cancers, it's going to get complicated, and you can't. If you try to design a checklist that took into account sort of an infinite number of invasive cancers, then I think everybody's head would explode because you can't design a checklist to accommodate every possible instance of how many cancers can be in the breast. So the main things will be for the largest cancer, and then the general things like the margins and the lymph nodes will refer to all the cancers.
Okay, Susan, we have time for one further question. It's from Dr. Leanne Wijanarko in Sudbury, Ontario. It's regarding PT staging. If the previous excision of a tumor is 1.5 centimeters, the re-excision residual tumor is 0.7 centimeters, do you restage the PT?
Yeah, this is always difficult when you have cancers in two separate specimens. And so one question is, are these really two cancers or is this one cancer? So that you could address by, was the original cancer at the margin, with cautery on it, and, so did you really think that the surgeon transected the cancer, and so now you have the same cancer in two specimens, or the surgeon resect a 1.5 centimeter cancer, now you're seeing a second, 7 millimeter cancer in the next specimen. So first you have to address that, one cancer or two cancers. I think a lot of times it's helpful to go back and look at the imaging. Because on the imaging, the patient clearly had, a 1.5 centimeter cancer, and the surgeon, transected a portion of it, then you can just stage it as if it was a 1.5 centimeter cancer. On the other hand, if it was clearly larger, if it was 2.1 centimeters by imaging, and then it really looked like they cut it off into 2 pieces, I would use the imaging to help put it into the right category. The trouble is you just can't add those numbers together, clearly. It's the same issue when we have the size on a core needle biopsy and then in the excision, and sometimes people have tried to add those two together, and that's more of a clear case. It's like taking an apple core out of an apple, so it doesn't give you 2 apples. You can't add the size of the core to the apple to get a much bigger apple. So that's sort of a clear situation where you can't add the 2 sizes together. So again, I'm afraid you have to go back and use your judgment, use the imaging. The imaging can be very helpful. Collect all this information together and come up with the best size. This sort of reflects back to one thing I didn't deal with, but one suggestion that's come up is that, the checklist could be used as a general area where you would collect all this information from all the different pathology specimens, and the pathologist is really in the best position to collect and collate and interpret all this information. And you could get this information from lots of different areas. So maybe the ERP-HER2 is from the core, and the size, is sort of imaging and gross. And then you have the first excision, and then you have the, a second margin excision, and then maybe the specimen was sent off for oncotype and it came back as ER negative, but when you look at the specimen, it's obviously ER positive, so so the pathologist can say, well, the immunohistochemistry is right and the oncotype is wrong. So the checklist would be sort of a document in which all pathology information would reside at the end of the day, which I think is an ideal situation, and maybe we can get to that sometime in the future. I mean, for right now, in most institutions, there's really no mechanism to do that at this point, to make it, sort of the center of all pathology information. But it would certainly be with a goal in the future that we could use the checklists in that way. And certainly the pathologist should be the person who can make those final decisions about what should be included in that checklist.
Thank you, Susan. On behalf of the Canadian Partnership Against Cancer and the National Staging Initiative and the Canadian Association of Pathologists, I would like to thank you, Susan, for a truly comprehensive, informative, and a very clear presentation today. This is our 3rd teleconference in our series of CAP checklist presentations, and I am sure there are still some procedural lessons to be learned, and we would welcome your comments and suggestions. Please send them along to the following email address, pathology@partnershipagainstcancer.ca. I regret that we ran out of time to answer all the questions today. There was at least the same number of questions that were not answered as were answered by Dr. Lester. I should remind people that the Canadian Association of Pathologists is having a symposium on breast cancer as part of their anatomical pathology symposium at the meeting in July. And Dr. Lester is going to be talking about the invasive checklist, and Dr. Anne-Marie Bulligan, the DCIS checklist. Plus, there's going to be a long panel discussion after that, so that'll be another forum to answer a number of these questions. As some of you may know, the Canadian Association of Pathologists is actively working to sign a memorandum of understanding with the College of American Pathologists that would see additional Canadian input into the checklist via both the CAP Cancer Committee and the CAP Protocol Review panels. As a reminder, both the live and recorded presentations are eligible for continuing education credits. The evaluation form for this presentation was previously distributed. Please return the electronically completed evaluation form to pathology@partnershipagainstcancer.ca in order to claim your educational credits. Once the WebEx recordings of this presentation become available, it will be made available for wide distribution via the membership of the Partnership's National Pathology Standards Committee and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. Finally, I'd like to thank the members of the Partnership's National Pathology Standards Committee for their valuable time and assistance in making this event so successful. Our next presentation is scheduled for tomorrow, February the 23rd at 1 p.m. Eastern Standard Time. Dr. Kay Washington was going to give an overview of the new CAC checklist for colorectal cancer. We look forward to seeing you then, and thank you very much for your attendance.